Hello everyone and welcome to set 5 of the part 1 questions. Let's get going. First question here, what is the fibrous band attached to the testes and the scrotum that aids in normal testicular descent? And then what is this structure called in females? So this is called the gubernaculum, which is a great word. And the female equivalent is the ovarian ligament and the round ligament of the uterus. Next question, what is Rindu-Osler-Weber syndrome? So this is also maybe referred to as Osler-Weber-Rindu syndrome, depending on whose ego is winning that day, or hereditary hemorrhagic telangiectasia. So it is an autosomal dominant disorder where you have telangiectasias in the skin and mucous membranes and possibly in organs like the lung, the brain, and the liver. And you can have little aneurysms in these telangiectasias as well. So these can actually cause bleeding, especially nosebleeds and GI bleeds. And because all of these telangiectasias and arteriovenous malformations, the heart has to actually work harder. And ultimately, this will result in high output heart failure. Next question. What is the difference between a case control study, a cohort study, and a clinical trial? And then which studies use odd ratios and which use the relative risks? So let's go through this. It's a bit long here. A case control study is a retrospective study where you study a group of people with a disease and compare them to a group of people without a disease. So maybe you're looking at people with squamous cell carcinoma of the esophagus and you're trying to find out if smoking causes this squamous cell cancer. So you ask this group of 1,000 patients with esophageal cancer if they've ever smoked, and then how much and when they quit and so on. And then you ask 1,000 people without esophageal cancer if they ever smoked. So this is retrospective, and you're going to be able to calculate the odds ratio with this one. Next one. So next we have a cohort study, and this is where instead of starting with these with the disease and working backwards, you generally start with the proposed risk factor, and then you see whether or not they develop the disease. So you look at a group of smokers, and then you see how many of them develop squamous cell esophageal cancer, and then you follow a group of non-smokers and see how many of them develop cancer. So cohort studies are usually prospective, but they can be retrospective as well. And this is going to let you calculate the relative risk in this one. If you smoke, what is the risk of developing esophageal cancer compared to if you never smoked? And then a clinical trial is prospective. This is an experimental study comparing outcomes from two different treatments or comparing treatment to placebo. So this doesn't actually use relative risk or odds ratio. All right, next question. What are the effects of NSAIDs on inhibition of prostaglandin E2? What role do prostaglandins and angiotensin II play on the renal arterioles? So that's a big, broad question there. So what are the effects of NSAIDs on that inhibition of the prostaglandin E2? So what does prostaglandin E2 do? Well, prostaglandin E2 is a bronchodilator and a vasodilator. So it is decreasing the smooth muscle tone in these tissues. So the bronchioles dilate and the arterioles dilate. So if you give NSAIDs, then when you inhibit cyclooxygenase and inhibit production of prostaglandins, you're going to get increased vascular tone and increased bronchial tone. So you have things like vasoconstriction, and then you're also going to see bronchoconstriction. Now, what role do prostaglandins and angiotensin II play on the renal arterioles? So we just said that prostaglandins are vasodilators. So in the kidney, they're going to dilate the afferent arterioles, and that is going to increase GFR because there's more blood going through the glomerulus. And what does angiotensin II do? Well, it tenses angios. It's in the name itself, right? So it is a vasoconstrictor, one of the most potent vasoconstrictors in our bodies. So angiotensin II is actually going to constrict the efferent arterioles of the glomerulus, and it's also going to increase GFR, infiltration fraction, because that blood that comes into the glomerulus has a harder time getting out through those narrowed efferent vessels, so that GFR rises. Next question. A female patient is brought to the clinic for evaluation of her genitalia. On exam, clitoromegaly and labial fusion is noted. Lab studies reveal elevated 17-hydroxyprogesterone levels. What is the most common form of adrenal hyperplasia? Which hormone levels are altered as a result of this enzyme deficiency? And then what are the clinical manifestations of this enzyme deficiency? So the most common form of congenital adrenal hyperplasia is 21-hydroxylase deficiency. Now, which hormone levels are altered as a result of this enzyme deficiency? So you have decreased aldosterone and cortisol and increased sex hormones. Then what are the clinical manifestations of this enzyme deficiency? So 21-hydroxylase deficiency manifests with hypotension. So you get volume depletion and hyperkalemia because of that low aldosterone. And you have masculinization of females because of that increased androgen, those increased sex hormones. Next, T cells are found in the paracortex of the lymph node between the follicles and the medulla. Which cytokines are secreted by the two different types of helper T cells, so Th1 and Th2? So T helper 1 cells are going to make IL-2 and interferon gamma. T helper 2 cells are going to make IL-4, IL-5, and IL-10. Next, a 25-year-old man complains of a scrotal mass and pain made worse by coughing or sneezing. A scrotal exam reveals a palpable scrotal protrusion with the Valsalva maneuver. What type of hernia is this patient experiencing? What type of hernia protrudes through Hasselbeck's triangle? What structures form Hasselbeck's triangle? We like to put like 5 questions each one of these. So this is a classic presentation of an inguinal hernia, and the important thing to remember is that you actually can't distinguish, at least on clinical exam, whether this is a direct or indirect hernia. Now, what type of hernia protrudes through Hasselbeck's triangle? So this is the direct inguinal hernia, and this protrudes through Hasselbeck's triangle. It begins its protrusion medial to the inferior epigastric vessels, while the indirect hernia begins its protrusion lateral to the inferior epigastric vessels. Now, what structures form Hasselbeck's triangle? Remember, this is the inferior epigastric artery, the lateral border of the rectus abdominis muscle, and inguinal ligament as well. Next question. What is the mechanism of action of the following antiemetics? Well, the first one is scopolamine. So this is an anticholinergic drug, and this is going to be an antagonist of the M1 muscarinic receptors. We usually use this to prevent motion sickness, to prevent seasickness. People are going on boats. And it's a little transdermal patch that we prescribe when you put it on the skin, usually behind the ear. Next, we have promethazine. This is an antagonist of both histamine receptors and the D2 dopamine receptors. Chemically, this is a phenothiazine like chlorpromazine and thioridazine and other antipsychotics as well, but we don't use promethazine as an antipsychotic. But that might help you remember this is going to block D2 receptors, commonly used. Prochlorperazine is also a phenothiazine, so it also blocks those D2 receptors. It's an older drug, not used very often anymore. Metoclopramide, also a D2 receptor antagonist. It's used often as a prokinetic to speed up the GI transit time. It's used in patients with things like diabetic gastroparesis. And the last one is ondansetron, which is actually quite different. This is a serotonin receptor antagonist. Specifically, it's going over the 5-HT3 receptors. It was originally used for treating really severe nausea, like when patients were receiving chemotherapy or post-op nausea. Now, especially because it's become more able to get because it's not so expensive, we use it for all types of nausea. Next question. What are the 3 endogenous androgens in order from the most potent to the least potent? So the most potent is DHT, so dihydrotestosterone is going to be the most potent, and then the next one is going to be testosterone. The least potent is going to be the androstenedione. So remember, DHT more than testosterone, more than androstenedione. And remember that the last 2 hormones can be converted to actually estrogen by those peripheral fat cells. Next question. How does a decrease in renal artery pressure cause an increase in blood pressure? Okay, so when the renal artery pressure drops, the kidneys start to panic. Juxtaglomerular cells start secreting renin, and this is going to stimulate the renin-angiotensin-aldosterone system to raise the blood pressure. Now, the basics of this is that renin cleaves angiotensinogen to angiotensin 1, and then angiotensin converting enzyme, ACE, converts that AT1 to AT2. So angiotensin 2 has 2 functions. It is a potent vasoconstrictor, so it will raise BP all by itself. And angiotensin 2 also stimulates the adrenal glands to secrete aldosterone, which also causes the kidneys to retain sodium and water. And when you retain sodium and water, you increase the intravascular volume, and that also will raise your BP as well. All right, guys, so that brings us to the end of set number 5. I hope you learned something. I'll see you next time.